Good afternoon, everybody. I'm Dr. George, and I would like to thank you for joining us for our webinar today. We are delighted to welcome Dr. Manisha Singh as a speaker for this afternoon's webinar, which is on chronic kidney education, tele-platform challenges, and the lessons learned. She'll present on this topic, and before that, we go ahead with a few intro and etiquette slides by Zoya.
Thank you, Dr. George. So this educational activity is a project of TexLa Telehealth Resource Center, a federally funded program with F. Marie Hall Rural and Community Health at TTU HSC, as well as Well Ahead Louisiana, with generous support from Health Resources and Services Administration of HRSA. This is just a reminder that CME credit is available for participants of this webinar, and a link to take the survey will be provided at the end of this presentation, as well as email to the attendees. These are some helpful tips for our webinar. Please make sure everyone is muted, and please type any questions or comments you may have during the presentation into the chat box. Dr. George will now introduce our speaker.
Dr. Singh is the director of the Home Dialysis Program for the University of Arkansas, as well as the Veterans Hospital in Little Rock, Arkansas. She is in charge of the Chronic Kidney Disease Education Clinic held at UAMS, and is self-described as an academic researcher at heart with a passion for education. She is an associate professor and is a co-director of renal modules for the medical students M2 level and a mentor for the practice of medicine training, POM, and she's actively involved with teaching residents from diverse specialties. Being an academic clinician, researcher, and educator has given Dr. Singh an unique insight into patients' needs as well as the research needs in the area of patient care, and we're grateful to have her today. Well, we'll hand over it to Dr. Singh.
Thank you, Dr. George. I always love hearing this introduction because it makes me look so much better than it actually is. I am a regular doctor and educator at heart, and I absolutely love kidney disease education. And the halo was not planned, so this is usually not the place from where I usually present. But you know, we just do well with what we have. Let me go ahead and share my screen with you all. Now I have one screen only, so when I share the screen, this part will go away. And if you have a question, feel free to unmute and ask, or put it in chat, and the moderators would review that. And here comes my screen. Okay, I am hoping you all can see that.
Yep, looks good.
Okay, so I'm going to take this part off just because it's interfering a little bit with the visual, and I'm going to close this captioning because when the CC goes on with my accent, it types in all kinds of very strange things. So some of it I mean, some of it I really don't mean. Now I'm going to talk about a little bit, of course, about conflict of interest. I, of course, don't get any money from more than what I get as a pay, but the research that I'm presenting has been supported by multiple people. Now, NKF has given us the Chastain Young Investigator Grant 2 years in a row to work on this project. And I'll be mentioning an Arkansas State CKD Advisory Council here that has been funded entirely by Baxter Healthcare. They have been amazingly supportive to us. And this project has also received support from Transnational E-Research Institute under a grant for all our statistics work, as well as a lot of coordination work that we need to do. So those are all the disclaimers. The outline of today's talk is that I would share what our past was, where did we start, and then I would talk about what we learned from that, and a little bit about perspective about where we think we're headed. Now, the background is that our institution, that's UAMS, joined hands with Arkansas Department of Health and started a pilot project. The plan was that we compared the platform. So we're not even talking about what we are going to educate. We're just going to see how are we educating, the tool of education. We were comparing face-to-face education with the tele platform. First, we had to ascertain that, are we going to take something away from the patient if we put them on? That time when we had started this project, this was a very new idea. I mean, this is way, way before COVID times. And we found compelling data that the two modalities were comparable. I'm going to give you a little bit more about how we came to that conclusion. And we found that significant change was noted in the patient's understanding of the disease process and being able to choose an appropriate modality for themselves. Now, all of us are providers at some level, but we're also patients at some level, or people. We would like to understand our disease better, wouldn't we? And we found that that actually is an enormous advantage to the patient to know what exactly is happening with them and to know what options they have. So what we did is we divided the whole state into different, and we reached out to the Arkansas Department of Health telemedicine sites. This was across the state. We picked 8 sites. These were in the hinterlands. Basically, some of these places are about 2 hours away and very close to the borders of the neighboring states. And we divided all the patients into 2 groups, and each of these groups were to have 3 visits. And the 3 visits were going to include over 5 hours of comprehensive multidisciplinary patient education. Now, so this was in 2 groups, 3 visits, and we had a UMS face-to-face group, and we had a telemedicine group. Okay, so those are the 2 groups. All the groups were going to get 3 visits. Okay, and this was real-time synchronous. So like right now, when I'm talking to you, when people log in from different places, that would have been the telemedicine group. And the people that would have been in the room, if I was present out there, would have been the face-to-face group. Why we picked this was because if we did anything else, we could not really say that only difference was the platform. That's all. There was no difference in the time. There was no difference in patient comfort. There was no difference in the weather. There was absolutely no other difference. So we thought we are going to take away a lot of confounding factors by having it organized like this. Okay. And one of the things that I feel made a lot of difference was we had a CKD questionnaire that was pre and post. So pre the first education class, and then post the first visit, and then after every visit. So the patients had to make one pre questionnaire, and 3 times they did the post questionnaires. And I feel this is very important, mainly because we are all very involved in something that we think we are being tested on. Okay. So I think this was one of the things that actually did give us the better results than if we had just presented learning thing. Now, just suppose that I had given you a questionnaire right now that, okay, I'm going to ask you questions from whatever I talk about just after the class. I'm quite sure quite a few of you would have been very interested to listen really carefully, right? So now when we looked around for tools, what exactly were we going to teach? There is a lot out there. NKF has wonderful material out there. Davita, Daxter, I mean, every kidney company in the world has a lot of education material. But we needed to refine it to our population and what our focus was. So we kind of did not want to overwhelm the patients with different things. And again, this was way before Zoom and COVID times, when now we are so much more comfortable with the tele platform. So what we did is we created this workbook. This workbook has what a tool is. That entire kit has the workbook and the slides, and there's a what do you know page for the patient, and what would you do. There are kind of some things that they can work with, putting in detailing. They can write on that workbook. What our results showed was that 47% of the face-to-face and 52% of the telemedicine patients reported that they did not have enough information to choose a modality. So when they come in, they really don't know what's going, what modality. I don't know if hemo is good for me. I don't know if PD is good for me. I don't know if I qualify for transplant. I mean, I would love to have somebody's kidney, was how they would start off. By the 3rd visit, this number had the maximum change. So this dropped down to, you can see 7% and 13%. The home modality choice, that's the national push, and we know that's the best thing for the patient, for the appropriate patient. The home modality choices more than doubled in both groups. So face-to-face, 25 to 67, and telemedicine from 22 to 50%. So when we cleaned up our data, it turns out that, nationally, if you think of these conversions, about 12 to 15% people choose home modalities. At the VA, we are pitiable. Last data that I saw was 2% people choose home modalities. And here we have 40 to 50% people choosing home modalities. So that's the gap. Yes.
Sorry to interrupt you, Dr. Singh, but we have a few non-nephrologists here. So if you be a little more elaborate on your what home dialysis or modality means?
Absolutely. Absolutely. Thank you for that question. So basically, when we talk about chronic kidney disease patients, we are talking about their 5 stages, right? So in early stages, our goal is to protect the patient's kidneys from getting worse. But in late stages, we need to talk about what do we do if your own kidney is not working. In that case, we talk about 5 choices. The first is, for most patients, appropriate would be to get a transplant. And that has the best outcomes long term. But that's not it's not a quick process. It's not, everybody cannot qualify for it either. You have to be in a particular state of health to be able to go through the immunosuppression that's required. In Arkansas, it takes about 2 to 5 years to get a kidney if once you're listed, and the listing process can take 3 to 6 months, depending on how quickly you follow through. The second option is doing PD, peritoneal dialysis. In this case, there is a tube that stays in the patient's belly, and the patient is trained to do this at home. They know how to fill the belly up. The peritoneum is used as a filter, and you keep the fluid in the belly for a little bit, and then it's drained out. And I have oversimplified the process purely because that helps me sell it better. But there are no needles involved. It's done at home. If you don't have electricity, you can do it. And we also have a machine that can do the cycle overnight for patients that can hook themselves up at night and they can take themselves off in the morning. Now, this is kind of convenient. Even children can do it, once trained. But somehow, and this used to be the preferred modality outside of the States in resource poor countries, this is still the favored modality because it is also cheaper. We're not going to a dialysis center for this. The third modality that we recommend is called home hemodialysis. Here, what happens is we get an access to move the patient's blood out of the patient's body into a machine, clean it up through that filter, the artificial kidney as we call it, and then bring it back to the patient. For this, we usually need a good access, like a fistula in the arm or the leg, and some people get a graft, and quite a few of the patients start with the tunnel catheters, which are the least preferred modality of access. Now, but this can be done at home too, provided we give them enough training. And this training is a little more intensive because you are going to move blood, you are going to use needles. And usually we used to prefer having a care partner, but now that's not as strict a rule. The fourth modality is what unfortunately most of our advanced kidney disease patients do, is go to a center and have this process done for you. There, a trained nurse will do this. They'll hook you up, put the line in, get you situated with the dialysis machine. In that case, those are very fixed chairs. Okay, so the patient will be given some kind of a schedule, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, and go there for 3 to 4 hours and get there. And that's also fixed. It's morning, afternoon, evening, whichever is your shift, you go there for your chair. Now, and this is just 3 times a week. Now, and whenever we talk about this, the way I present it to the patients, and which I really believe in, is that this is the least amount of dialysis you're going to get, because this is just 3 times a week compared to at home, you do it 5 times or 6 times. It's your machine, your home. You get as much dialysis as you need. And with peritoneal dialysis, actually we do 6 or 7 days. So it's working almost as good as your kidney. Nothing is as good as your own kidney, but this is the closest second that I can think of. The fifth option is not doing any of this. Many of our patients are appropriate for palliative goals. And in that case, we upfront have a discussion with them that, okay, they tell us that, especially our very old veterans, they say, I've lived a good life. I like to go fishing and I do not want to be on any kind of a machine, no matter what. In that case, we say, okay, fine. Then we just team up with palliative care doctors and keep them comfortable, which is quite appropriate. Dialysis is not fun for most patients. So those are when we talk about home modalities, we're talking about peritoneal dialysis and home hemo, and in-center is when they go to a center. So pretty much broadly, those are the 2 groups that I'm talking about. Okay. So we found that now, why do we have this kind of a, gap between home modalities and in-center? Why do we have such few patients out there? Mostly because, multiple factors happened. Dialysis units were lucrative financially. patients have very little confidence in themselves. If I was told that you can do this yourself, I think upfront for the first time when I'm hearing this, I too would not have as much confidence. And then you're sick when you start. So at that time, you just feel that I just don't want to do this on my own. We have multiple plans in place to address all of those questions and queries. As the patients get educated, these questions come up. What am I appropriate for? What is my life's priority? And how do I handle this? Okay. So what we found that in patients that completed even one education visit and needed to start renal replacement therapy. So now this is not just talking about choice. You see, in the beginning, we talked about our education package. And then at the end of education, I ask you, what would you like to choose? Now here you're sitting comfortably, you can choose what you want to choose. But when it actually comes to doing what you've decided, that actually reflects about how good this education was. And so even with one visit, we found that in our patients that started dialysis, 47% started on a home modality or received a preemptive transplant. So this is I believe, quite a win for us. Now, this was, and the finest point was that the patients were able to make a choice, an informed choice, regardless what modality they chose. So if they chose to go in center, they went there knowing that they had other choices, and it was still appropriate for them. They did not have anybody who could train. They were, partially blind with amputations. I mean, there were a lot of barriers, and they decided that, listen, in center is good for me. That makes complete sense, right? So this is a graphical representation of the same thing: home hemo, in-center, peritoneal dialysis, no dialysis, transplant, and not enough info. This was the pre-education. And you see that pretty much the face-to-face and telemedicine platforms were comparable. And the results, this is when we put it all together. So how the things started changing. And you see the maximum change starts happening in not enough info. So they now had information, all right? And in the telemedicine group, it's the same thing. When we put those graphs side to side, you'll see that it kind of compares absolutely. You could just, put it on top of each other and it could be the same graph. Okay. The only difference is coming because of the number of patients that were different. Slightly, we had fewer patients in the telemedicine group. So what we learned from this whole project was the good. So when educated and given a choice, more than 50% of patients will advance chronic kidney disease will choose a home modality. This is like goal of the nation. Patient wished that they had been educated earlier. And then patients expressed a feeling of hope and empowerment as soon as they went through this class. The bad was that we really didn't have as many referrals as we thought we would have upfront. So this is one of those challenges that we had to have. And that pointed us towards need for provider education. Many providers actually don't think that, this is even required. I mean, how many people make a referral for just education? Okay. And there was a lot of ugly too in the system changes that we needed, the infrastructure intelligence that we had. Now we are, we are not, in the top 5 states as far as resources are concerned. So I'm going to talk a little bit about the ugly part. We needed some system changes. Most important was infrastructure intelligence development. Okay, so how do we get that access to the patient? What resource? I mean, what the tele platform was not strong that time. Now, Zoom, I mean, there's a link and I link in and we're in. But that time we were trying to set up a room. We needed, and get the patients there. We needed community engagement because these are very far out sites. The referrals were not there. Patient's driver wouldn't show up. So there was a lot that, nobody thought it was important. The telehealth platform as such had its own challenges. Okay, there's a provider challenge. Now, if you're looking at me right now, you see that I have deliberately placed myself in such a manner that at least you can see my shoulder and my face. Okay, you should be able to see my hand. If I was presenting from what our telemedicine sites present as, you should be able to see my hands. But if I was presenting like this, you will have a hard time trusting me. Okay, especially when you're a patient, it's not good communication. Okay. So that part we had to educate our educators about how to teach on a tele platform. And then for patient challenges too. I'll be telling you a little bit more about this. So in infrastructure challenges, what tools do we use? Okay, so are we going to use laptops? Are we using desktops? Are we using phones? The internet access and stability, we needed a lot of that. You need at least medium to high bandwidth to be able to present and send the educational resources over to the patient. What devices are they using? If they're using handheld phones, which have very small print, they're not going to be able to read that book if they have the PDF version. And and if they have a big phone, I mean, is the electricity enough to power all of this? We needed some buy-in from the policymakers. Somebody needed to pay for these infrastructure changes. And luckily for us, we had the grants to work with. But going forward, we need the policymakers to be invested heavily into infrastructure development. But don't let that be a deterrent to, if you're planning to do something like this, don't let that be a deterrent, because that is much more developed now than it used to be in the time when we were doing this. Now, in just the internet access, now this is much more recent data that in internet access in Arkansas, only 600, yes, you have a question?
No, I'm sorry.
Okay, so 600,000 people in Arkansas don't have a wide internet connection that cannot even download at that speed that we needed downloaded. So if you hear your educator talking like this, you're lost, right? And especially when you're trying to educate somebody, they, the moment the attention span is less than 20 seconds there. So if there is a breach, I'm going to lose that patient's attention for that class and they're not going to come back. Now, we have another 200,000 people in Arkansas who have no internet providers where they live. So it was like, we could only educate places where they had very good bandwidth. We did have a governor that was supporting us quite a bit, and not just us. I mean, for the state, the governor had a plan to have broadband population in any center that had more than 500 people. Now, this was a 2020 goal at that time, but then, of course, COVID hit and a lot of it has changed. The provider challenges, like I said, learning tele-specific teaching style, the comfort and competence on telemedicine, because many of us were trained in the face-to-face training groups. We're very comfortable when we're dealing with people in front of us. I can make eye contact, I can read body language. And, and I used to get a lot of feedback from my audience and know which way to take the conversation. But that you can't have on the tele platform, when you're staring at a screen half the time on Zoom. Also, people, like I understand completely, we turn the cameras off and that's just the right time to answer an email. So it is challenging. Then that infrastructure and leadership support. I mean, would our hospital give us a space for this? Would they allow you the time for it? And how are you going to bill and code for this? You're going to take time out. You're going to use the resources. Somebody's paying for it. For our institute, we opted for no billing for education for the patients. So there's no billing there. Hospital bears the cost. And we feel that it is actually cost effective to do that. And then, of course, patient interaction satisfaction, we miss that. The patients also miss that. We also miss that. Okay? That our goal is comfort, hope, and healing. And it's very hard to provide that on a tele platform. It's hard, but not doable. Okay. So what tips do I share with you here? So one of the things that that I really warmed my heart when I got an email before to say that can we just join in a little early to test the technology. That is very important that we practice the technology prior to the class, because right now here we have all the providers, but there you'll have patients, they're not feeling too well, they have 10 other things to do, they're usually at home, and if we lose them for a bit, they're probably not going to come back for that class. And know how to find help. You need your IT person's support person right there. They should be one phone call away. And you might want to have a staff run the patient through the process prior to the class. So explain to them that, listen, you're going to log in like this. That's where the provider is going to be. This is how the class is going to run. This is how much time it might be taking. Have a kind of practice run through. And also alert the patients that there are others on the call, because patients, when they see a provider, they start wanting to share their experience and they might give out some of their privileged information, which we definitely don't want to discuss on a combined class. Now, patient challenges were there. There was, what are the access to appropriate tools and educators? This is universal. We have 4 educators for the entire state at that time. Internet and devices, now all of this had to be stable from their end and our end, both sides. Age, comorbidities, and need for care partner. Quite a few of them needed their grandchildren to be there to be able to help them log in. Learning style and education level. This is something we really don't think about when we're thinking of patient education, but this became a big sore point for me later in time, because right now the project that we started trying to see if our pharmacists could educate and the same, because now we have a full curriculum We know this works. We just need the education out there to the person that needs it. But we're not getting any patients to sign up because our workbook is designed for 8th grade and above reading level. And when patients see that workbook, some of the patients in the areas that we're trying to target the Delta now. They look at a book and they say, I didn't want to read a magazine in my time. I'm not going to go through a book. So we need to change that some. We probably want to decrease the education level down some of the way the workbook is formatted, and also to have more pictures in there and make it worth their time. Travel concerns. Now, our patients had to come to the nearest telemedicine clinic to attend these classes. Sometimes that becomes a problem, but now the last part of our venture had been when we just asked them to sign in from their home. If they had an internet connection, that was going to be fine. So one of the bads were that referrals were very poor, and we couldn't understand for life of us what happened, because, whenever we talked to primary providers, they were very keen to join in. They understood the patients needed it. We went in it, but the referrals were very poor. So we understood that we probably need to educate more about, say, chronic kidney disease and how harmful and the lifespan. I mean, the patient who's on dialysis, some of our patients have less of a lifespan than people who have cancers. But, that awareness is not there. In the provider groups, there was a study that showed that in the primary providers that were taking care of patients with chronic kidney disease, only 14% were billing for CKD. Now, it's not that they didn't take care of any factors for CKD. Probably they themselves thought that they were not doing anything for CKD. But that also shows that big gap where primary providers do not think that they are also taking care of chronic kidney disease when their patient with diabetes and hypertension comes to them. We also needed public awareness. It turns out that, many people know about diabetes in the society. They know about hypertension. Then, we have the breast cancer run. But chronic kidney disease is unfortunately not talked about as much. Considering how big an issue it is, it needs to be talked about more. So how we approached this was that we reached out to the potential stakeholders, the insurance agencies that were working in the state, multiple different like dietitians, pharmacists, our College of Public Health representative, and we kind of got core group together to form this Arkansas State CKD Advisory Council. The only mission for that council is to increase CKD awareness, detection, and education in Arkansas using community engagement activities. So we go out there to churches, wherever we can go and talk about kidney disease. We created posters. I'll have a copy for you there. And basically this committee is divided into 4 major arms. One arm was just focusing on understanding the data. One arm was talking about finances and cost. This was going to inform our policymakers. And then arm 3 was about quality initiatives, to take it forward as a research project. And arm 4 was only focused on education and chronic kidney disease, under which this talk has been developed. So with the focus arm analysis, we found there were a lot of cool things that we found. So we analyze the cost savings analysis, dollars spent to what services you get. We developed some CQI projects. And then, of course, we keep updating our tools of education. We developed a white paper that compared Arkansas data with the national data, and we inform our providers regarding how they're doing nationally. Now, this kind of, providers and especially physicians, we like data. We like to know, okay, am I not doing as well as this guy? So then, our hope was that when we present this data, more and more providers will get interested in taking up this project. We found out about the cost, and it turns out that in Arkansas, it's actually less expensive than many other states in the country. And this really helped our hospital devise the cost plan. And that's how we get all the support we get from the hospital, because we can show that in Arkansas, we are doing well. Then we made this for approaching primary care providers. We made a 10-step checklist, what primary care providers can do to manage early CKD, because most nephrologists, we are backed up 3 to 6 months. I don't know what Dr. George's clinic schedule must look like, but for a patient to come to my clinic, it can be anything between 3 to 6 months. Now, so we like to keep those spots for advanced chronic kidney disease patients. Early CKD stage 1 and 2 can be handled by primary providers. All we have to do is target the drivers of the disease. All primary care providers need to know is that, how do I do this? And we developed a 10-point checklist that you can incorporate it in your EMR if you'd like. You can print out it, keep it by your side if you want to check it off. And it's very helpful in knowing just what to do with your kidney patients. And you can also bill for it. And we have the billing codes out there, and so that kind of helps. And we also have a rationale for why we have those 10 points there. Now we keep presenting live wherever we can. I go to any opportunity that I can get to teach about chronic kidney disease to the primary provider areas. The Arkansas State CKD model, this is the first of its kind from what we know. And I think every state should have one where you can compare your own data with rest of the country and see what you can do better, what you can do worse. If you want to look at the white paper, I have a link at the end of the talk where you can go and read the white paper. It's it might not be it's interesting reading for me. Okay. So it's a big paper. Now, patients and providers and all the people in the regions, we are encouraging them to join the council. In COVID times, of course, we had a very hard time. Everything was, COVID related, but now we're getting back on track. Now, for infrastructure, what we found is that there is a digital health institute with UMS. Now, they were doing different education. They were doing stroke, they were doing prenatal care. And we found that that was a very good home for us to reach out to. They already had a lot of setups. We could use that. Now, VA itself has a very good telemedicine program. And I'm quite sure that, anyone who wants to set up in the VA system can do this pretty easily. Then we have these copies we made digital copies of the workbook and we gave it out. We made tutorials and we put it up on Patient Learn on Demand. So patients can go back and listen to those talks online. I'm not a big fan of this because I feel it becomes just like any other resource out there. And there are a lot of very good resources, but it does help us some in directing our patients with what we have created. And provider education with CME activity has been helpful. And we have a Learn on Demand module for providers, primary care providers, to go through that managing of early CKD. And for public awareness, we have our website, that's Know Your Kidney Number, that is specifically directed towards Arkansas and our UMS ventures about kidney disease. We partnered with Arkansas State Kidney Commission also, and they're also helping kind of take this word forward. Now, this whole model of education has become part of our chronic kidney disease clinic standard of care. So now actually, once it got started, I don't have to do much with it. What we have finally done is we have 6 sessions of 2 hours each, which are taught real time over tele-platform and face-to-face. This is divided between different educators. The first 2 classes are taken by the APRN, and then one by dietitian, that is specifically only for diet in CKD. Then a social worker who goes over coping with chronic kidney disease, insurance status, any other anticipated social problems that the patient could be having. And then one class is taken by the pharmacist. We left one class, and this we run in recurrent sessions. So anybody who's missed maybe say class 2 of their group, they can easily join class 2 in the next group, because this is just 6 sessions going back to back. We give 2 weeks off in case patients have something else and we need to, give that cushion out there. So what was the time and effort needed? Okay. What we were doing, and we still try to do, is quarterly Zoom meetings for the whole council. That's about an hour. We have bi-weekly core team Zoom meetings. We go over, how many patients came through, what were they doing. This is just to keep the team on track. Now I have to do this less and less. Initially, it was a lot more intensive. Now it's like a system that's running on its own. There are uncountable hours that we've spent developing ideas off screen. What I presented to you is after years and years of refining what our initial ideas had been. Now we had to take a big break during COVID times. And also we lost a lot of our personnel. They got sick, they left. So we had to retrain some trainers. The portals that we utilized were Cisco, Zoom, and even Epic has its own platform. And basically any media platform that you can get. For me, I prefer Zoom mostly now, just because I've become very comfortable with it. And we keep updating our education too. So now that workbook is, we're working on the 3rd edition on that one. We're also working on a Spanish version of it. So challenging times, right? 1921. So this face-to-face arm was completely gone at that point, but we were able to keep education going over tele-platform. Now, this is just to remind you about how good this and how strong this platform is. Because when we had started, we were just trying to see if it is going to be good enough. There was a point in time where this was the only platform. This had to be enough. And our education we were able to resume, and we keep growing our home program because of this education that's ongoing. Now, this was all the good part, right? So we zeroed it on this part that patients had wished they had been educated earlier. So our newer editions are about earlier CKD. So earlier we were targeting only CKD stage 4 and 5, but now we've gone 3B downwards. Okay. So far we talked about all the barriers that we felt and addressed, right? And we rewrote the workbook GFR 45 and under, updated the video on demand. Then we continued the tele platform. This was all about what we felt we were doing good. So then what happened is there was a surprise in store, because in the new plan, when we got the new edition, when we launched it, and we offered the same thing to the patients, tele platform face-to-face, it turned out that we were thinking that we'll do 3 arms. We'll do self-study, telemedicine, and face-to-face. And we asked the patients to choose their modality. How would they like to be educated? This was under this whole thought that, patients should have patient-directed learning process. So what patients preferred, and this was a surprise for us, most of our current patients wanted to come in face-to-face. Now, I don't know if it was because of, post-COVID getting tired of the tele platform, but some of them said the topic is too important. I have digital fatigue. I get distracted on my own. I don't understand. I don't think I'm understanding this right. I do not like watching the screen. These were the things they told us. Now, so some of them wanted to combine. They wanted to come in for first 2 when they're understanding CKD. They wanted to come in face-to-face, and then they wanted to go hybrid, go home and learn more. Okay, so at this point, we're collecting data on this, but this has been an unusual trend that we noticed. I am still going to say that telemedicine is a very strong platform, and we should keep that going, but we should also have a strong face-to-face arm that's going along with it. Now, for future, I think we'll have to have patient-centered or tailored didactics. That is, somebody is a visual learner. We need to have more videos for them. Somebody is a audible learner. We need to have more conversations with them. Some people can read better. So we'll need to tailor it down to individual patient. That part I'm able to do better in my clinic. My CKD clinic is very strong on the education part. And we also don't comprehend about the time that it's going to take for us. Now, when we surveyed our VA patients and renal nurses, so we wanted to see how much time does it really take in getting one patient through the education. The time that they said was very variable, like 2 weeks to 3 months. We were talking about training for home dialysis. And I could understand how can it be that variable. Sometimes it turns out that the patient, so you have to modify your education based on the patient's understanding of your disease. Some of our patients were walking into the class very slowly, from the parking to their education class. That walk was very long. So we had to actually plan that when they come in, they should be parking at a particular parking so that they can walk in sooner. And, do they need their wheelchairs up, out there to receive them? So you need to know your patients still. And right now, there are so many resources that there is a thought paralysis. So you can't tell the patient to just go and look at whatever is available. You need to direct. Okay? And we're going to make this patient-centered modules. Now, these are the posters that we created, and we are handing it out across the state. We like to put it in every clinic out there so that every Arkansas sometimes sees this poster and comes to this understanding that if you have diabetes and hypertension, then you probably are at very high risk for kidney disease. You need to get, have that conversation with your provider. So who are we trying to educate? We are trying to educate the providers, the public, and the patient. I've talked a lot about the patient education, but what I would like to take a second for is to talk to you about disparity gap. When I talked about internet bandwidth, we understood that only people with internet could access this education. People without the internet who were not coming for face-to-face, they were never going to be able to access this. right now, even in the patients that we are educating, already a literacy level barrier has come. The workbooks were created for 8th grade level. People with 3rd grade level are not able to read that. So there is a barrier there. So they're not going to be educated as well as those with 8th grade reading skills. And there is a massive trust issue. Whenever we have patients from low, from challenging socioeconomic backgrounds, their trust for the hospital system, us, and our trust for them, both of it is a gap that we need to tide over. So the ethics of this education is again, pretty hard on the disparity gap. There was a question that are we really increasing the disparities by doing this? But not doing it is doesn't make sense either. And then it is expensive. It is expensive to educate. We need those platforms. We need those educators. We need those tools and resources. It is expensive to educate, but it is more expensive to not to do that, because a non-educated patient is going to come to the ER. They are going to come make the worst possible choices for themselves. Our mortality, morbidity, and the whole healthcare system for the whole state is going to go down. So, with that in mind, we're still trying to figure out how best to take it. And I think once we go into the patient-centered didactic models, we'll be able to bridge some of these gaps, but there will always be some gap that is there. This was the chunk of the talk. The link at the bottom of this page is knowyourkidneynumber.ums.edu research. On that page, you'll be able to see the white paper. You'll also be able to see other publications that we've done on these topics. And you'll be able to see much more in detail about the way we set up the classes. Would you like me to talk about anything more than this? Questions?
Thank you so much, Dr. Singh. That was such an informative and insightful talk with a focus on, as you said, comfort, hope, and healing. Don't forget to fill out the session evaluation survey to obtain your CMEs. And we will now open the floor to questions and discussion.
How do I, I'm trying to unshare my screen unless you'll want to see the screen. Okay, I'll just leave it in for a minute.
Dr. Singh, can you elaborate when you say interactive patient education modules? Can you just give us an insight into what that means?
So basically, you want to see your patient and you want to understand, it's a good idea to get educators on board for this. It's a good idea to understand what is the patient's learning modality of choice. And then you don't want to just give them that modality and let them be. Okay, so we have that pre and post questionnaires, and somebody walks them through that education. So get a group of, say, you have your visual learners, put them together, show them the video. But while you're showing them the video, you can't do let the whole video go through and through. You want to stop the video at times and hear their comments. Okay, so make it interactive there. It is usually real time. The recordings that we left for the patients on Patient Learn on Demand, those are not interactive. And I'd see that patients only go back to it. The ones that go back to watching the recordings are the ones that have attended the interactive sessions, because they're just going back to hear something that they might have missed. But I don't see any patients who've never been educated actually want to take all the time to go and look at just a recording.
Thank you.
Dr. Singh, how do you handle patients who are interested for transplant? How do you channel them in that direction?
Yes. So what we do is that I have a checklist. Again, I am a big fan of checklists. I have a checklist in the clinic, which is for all providers whenever they come in, that GFR under 30 referral for transplant evaluation should be made. So this is GFR under 30, anybody. So first, your providers need to be aware that they need to be looking at a GFR. Now, this referral can be made by any provider, but most often other providers miss it. At least when they come to kidney clinics, if the patient's GFR is under 30, we make referral to our transplant center or any transplant center for their evaluation. And at that time, we start preparing, unless there is a contraindication. If the patient is an active smoker, if the patient has an active malignancy, or if they have very significant heart or pulmonary disease, then we tell them what the barriers are and how to, tide over that. And so our referrals are done at GFR 30. We don't even wait for the late stage CKD for that. But even the learning modules, we have this page in which the patients are encouraged that those are your modalities. And patient just starts generating that question that when can you refer me for transplant?
How do you get the primary care physicians of the community involved in this kind of a venture? How do you get them into your into this venture?
So I have, because I'm, I keep trying to get to their didactics. I have a talk on just CKD management, early chronic kidney disease management, on the 10 steps of CKD. And I take that and go to their any seminars that they're having. And also basically any platform that I can find, anybody that would invite me for teaching, I am available. I mean, that's been my way of reaching out to them.
Do we have any other questions?
Something in chat I didn't see. Yeah, that no, you're okay. Thank you. Thank you, Mr. Rawat.
Thank you for thanks to all for all your participation. We would like to present Dr. Singh with a prestigious TexLa TRC Challenge coin for the wonderful webinar today. I would like to especially thank Laura Rawald, who has been the manager of this and who has brought this program together, along with Rans, who has helped us with the IT. I also like to special mention, of course, Dr. Santos. You are physically absent, but you still, I know, are around. So, and I really enjoy, being part of this whole process. Thank you again, Dr. Singh, and keep up this great work. Have a good day.
Thank you so much for giving me the opportunity.